Welcome everyone. My name is Ashley Moore and I am currently a student in the Doctorate Nurse Practitioner program at UAMS. Today I'll be presenting EKG interpretation basics for emergency nurses. This presentation is designed for novice to intermediate emergency department nurses who are looking to strengthen their confidence and accuracy in reading cardiac rhythms. Over the next 30 minutes, we'll walk through the components of an EKG waveform, learn how to calculate heart rate, differentiate between normal and life-threatening rhythms, and explore appropriate nursing interventions guided by ACLS protocols. So let's get started. This presentation, as I said, is for emergency room nurses. And why is this so important? EKGs, or electrocardiogram interpretation, is a critical skill for nurses, enabling early recognition of life-threatening cardiac events such as STEMIs, ventricular arrhythmias, and asystole. In high-stakes environments where every second counts, the ability to rapidly interpret EKGs can mean the difference between timely intervention and avoidable deterioration. This session is designed to build foundational competence and clinical competence in EKG interpretation for frontline nurses. By the end of this session, I hope that we can accomplish three things. We can be more competent in identifying EKG waveform components and calculate heart rate. We can differentiate between normal sinus rhythm and a few life-threatening rhythms. And lastly, we can describe initial nursing actions based on EKG interpretation. This lesson is grounded in Knoll's adult learning theory, which emphasizes self-direction, practical application, and relevance to professional practice. By using rhythm strips, clinical scenarios, and tools like simulation, we appeal to adult learners' need to connect theory to real-life work. The teaching strategy used in case-based learning, supported by multimodal delivery such as visual, auditory, and kinesthetic. This approach aligns with the Quality and Safety Education for Nurses, or QSIN framework, especially the competencies of clinical judgment and safety. Let's start with the cardiac conduction system. Understanding the heart's electrical conduction system is the foundation for interpreting any EKG. This short video will walk us through how the electrical impulse travels through the heart, originating from the SA node all the way down to the Purkinje fibers, which creates a pattern that we see on the EKG strip. Now that we've watched this brief video, you can see how the SA node is the pacemaker. The sinoatrial node is the heart's natural pacemaker. It initiates each heartbeat, generating an impulse that travels through the atria. Next, we see in the video the AV node, which is our gatekeeper. The atrioventricle node delays the impulse just slightly, allowing the atria to fully contract, and then it pushes the blood into the ventricles. This slight delay is crucial and is reflected as the PR interval on our EKG. Thirdly is the bundle of His. As the electrical impulse passes through the AV node, it travels down to the bundle of His, then splits into the right and left bundle branches. These paths deliver the impulse toward each ventricle, going down to the Purkinje fibers, which is the final conduction outlet. These Purkinje fibers rapidly spread the signal through the ventricular muscle, causing the QRS complex we see on the EKG. This is where the ventricles contract. Now, how does this tie into what we'll see clinically in any environment, mainly in the ER? Interruptions or delays in any part of this pathway, like a block in the AV node, can cause dangerous arrhythmias, which we'll learn to identify later in this presentation. Now let's switch gears just a little bit. Correct lead placement is absolutely critical in EKG interpretation. An improperly placed lead can mimic or hide dangerous cardiac conditions, including myocardial infarctions. That's why every emergency nurse must be confident in accurate electrode positioning. Starting with the precordial leads, V1 through V6, these are going to give us a horizontal view of the heart. As you can see in the diagram, V1 is placed at the fourth intercostal space on the right sternal border. V2 goes on the left sternal border at the same level. V3 is between V2 and V4. V4 is at the fifth intercostal space in the mid-clavicular line. V5 and V6 continue at the same level along the anterior and mid-axillary lines. These chest leads are crucial for detecting anterior and lateral wall ischemia. For the limb leads, we place the right arm and the left arm electrodes on the upper arms or shoulders, and the right leg and the left leg on the lower torso. These create a standard limb lead that are 1, 2, 3, and the augmented leads AVR, AVL, and AVF. They give us the frontal view of the cardiac activity. A couple of common pitfalls to mention: placing V1 and V2 too high can produce a QRS complex that mimics a septal MI. Also, if limb leads are reversed, it can change the axis and lead to a misinterpretation of rhythm or even suggest the wrong location of a STEMI. Clinically, if a rhythm doesn't fit the patient's symptoms or presentation, it's always better to double check the lead placement before escalating or activating a STEMI alert. Now that we've covered the correct lead placement, let's connect the dots to which each lead actually tells us about the heart. This chart breaks down which part of the heart each lead looks at and how it maps to the coronary arteries. Now let's start with the inferior leads. If you look on the diagram here, the inferior leads are located in the bottom left portion of this diagram and covered in red. Those leads, as you can see, are 2, 3, and AVF. These show us the inferior wall of the heart, which is usually supplied by the right coronary artery or sometimes the left circumflex, also known as the LCX. And the right coronary artery is also referred to as the right or RCA. Changes in these leads suggest an inferior wall MI. Next are the lateral leads, which we can see in this diagram are in purple on the picture. There's one in the top left corner, the middle right above the inferior lead section, and then in the bottom right. These look at the lateral wall, which are supplied either by the LCX or the diagonal branches of the LAD, which are the left anterior descending artery. ST elevation in these leads point to lateral ischemia or infarction. Then lastly, we have the anterior and septal leads, which are covered in the green box in this diagram, which is in our top right, then it kind of cuts over into the middle. Those are going to look at V1 through V4. These monitor the anterior and septal walls of the heart and are primarily supplied by the left anterior descending artery or the LAD. This is crucial to assess because an LAD occlusion is often referred to as the widowmaker. And an actual STEMI alert, one of the first things that we're going to check where there is ST elevation and which lead the ST elevation is in, because that will tell us which part of the heart is in trouble and means which coronary artery is likely blocked. This will kind of help us to guide and localize those myocardial infarctions and then communicate clearly when we are going to activate the cath lab team. While we're not going to explore every rhythm in detail today, this session just builds on the foundation that we can further develop those skills that you can apply and practice in the future and continue down your path of learning these cardiac rhythms in the future. And I will provide resources throughout and practice assignments as well. This slide here is a great visual representation and also is great for those that rely on reading and writing to show those main arteries that we talked about. You can see on the bottom left the right coronary artery, left coronary artery, that circumflex artery, and then the left anterior descending artery. And the EKG rhythm strips above can show you different ST changes depending on where those arteries are being affected in those certain lead placements. Then if we look over on the right-hand side of this picture, you can see different ischemic changes which are attributed to the coronary arteries supplying those areas, and further showing you which leads can affect ST segment changes depending on which part of the heart is affected. Now let's break down the EKG waveform. As we get into this section of the presentation, I don't want you to get discouraged. Even as a seasoned nurse working in the emergency department, this part of the heart requires constant review because the heart, even though it is a muscle, it is a big electrical circuit. And there are cardiologists that will specialize just in the electrical components of the heart, and it can get very confusing. So if you have any questions, please don't hesitate to raise your hand, and we will stop and repeat this and try to explain it in different ways so you all can understand. Every rhythm we're going to analyze is built from these same electrical components. If you understand just this baseline, you can kind of build toward recognizing both normal and abnormal rhythms. So let's start with the P wave. This represents atrial depolarization. And what do I mean by depolarization? It's the electrical signal that travels through the atria. You should only see one P wave before every QRS in a normal rhythm like sinus rhythm. Next is the PR interval. This is measured from the beginning of the P wave to the beginning of the QRS complex. This tells us how long the impulse takes to travel through that AV node that we discussed earlier. A normal PR interval is usually between 0.12 to 0.20 seconds. If it's any longer than that, we may be looking at a first-degree AV block. The QRS complex represents the ventricular depolarization, and now this is when the ventricles are going to contract. This interval should be less than 0.12 seconds. Now, if we start to see a widened QRS complex, this can indicate a bundle branch block or a ventricular rhythm. And then lastly, let's look at this T wave. The T wave follows the QRS and represents ventricular repolarization, or the heart resetting or resting for the next beat. Now, this is where it can kind of get interesting. We can see T wave inversions or peaking, which can signal ischemia, electrolyte disturbances, or even evolving MIs. This is actually pretty cool in critical settings because if you have newer residents or if you are getting a EKG on a patient and you see these T wave changes, then that can signal to you to alert the doctor and maybe catch a STEMI before it even happens. You may also see a U wave, which can come after the T wave. This is less common incidental finding, but it can appear, and we mainly see this with hypokalemia or low potassium or bradycardia, which is our heart rates anywhere less than 60 beats per minute. Later, we're going to apply all this knowledge to actual EKG strips, so don't stress out right now if this seems overwhelming. But for now, let's just focus on identifying these components and knowing what they reflect electrically within the heart. So now that I've just spit out all of this information at you, let's just take a second to stop and look at this picture. So as I said, let's start on the left. We have the atrial systole, which is the atrial contraction that forces blood into the ventricles. Then we're going to move on to ventricular systole, which is technically our first phase. So the ventricles are going to contract and it pushes the AV valves closed. Then we're going to move into the second phase where the ventricular systole, it has the semilunar valves which are going to open, and then blood is going to be ejected out into the body. Next, we're going to move on to ventricular diastole. which our semilunar valves are going to close, and then the blood is going to flow back into the atria. And then lastly, ventricular diastole, which is our late phase, but the chambers are going to relax, and then blood is going to fill the ventricles passively. So this whole system here is going to allow for that lub-dub that we hear when we listen to somebody's heart. And this is basically the heart filling, releasing the blood into the ventricles filling, and then pushing that blood out to the body to supply energy and nutrients to the body. Does anyone at this point have any questions for me? Okay, that's good. Let's go ahead and move on. Now let's start getting into the fun stuff. There are two key methods to calculate heart rate from EKGs. We can use the 6-second strip method or the large box method. We're going to also utilize these two methods to calculate heart rates from real rhythm strips. So it's about to get really fun. I hope you're as excited as I am. Okay, so let's start with the 6-second method. I'm going to grab my pointer here. Each of these boxes represents 0.2 seconds. So we have 1, 2, 3, 4, 5. So 5 boxes represents 1 second. If you can see here at the top, there are these tick marks. So let's count those. So we have 1, 2, 3, 4, 5, 6, 7. And within each tick mark, there are 5 boxes, which represents 1 second. So we have 1, 2, 3, 4, 5, 6 seconds. So this is our 6-second strip. This method is very good for those quick situations where you need to rapidly identify somebody's heart rate, and it is also good for rhythms that aren't regular. So in order to calculate utilizing this method, we're going to look at the QRS complexes, or our large spikes here. So we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So once we do that and count those QRS complexes, we're going to multiply that by 10. So 10 QRS complexes times 10. So our heart rate here is 100. This is a textbook example of normal sinus rhythm, or NSR as you may see it. First, we can see that each QRS complex is preceded by a clearly defined P wave. So here's our P wave, our QRS complex. This tells us that the electrical impulse is originating in the SA node, and that's what defines a sinus rhythm. Now let's look at the regularity. The R to R intervals are consistent across each strip, across the strip, which indicates a regular rhythm. So we've defined that the heart rate here is 100 beats per minute, which falls within the normal sinus range. Now, let's go ahead and start introducing the large box method just to verify this. This method is normally used for regular rhythms, and it is a little bit more precise. So we're going to pick any 2 consecutive R waves. So we have our P, Q, R. So the 2 tall spikes. So these 2 are right next to each other. We're going to count the large boxes in between them. So we have 1, 2, 3 large boxes in between them. Now we're going to use the rule of 300. So we are going to divide 300. We're going to divide 3 by 300. So 300 divided by 3, and that gives us 100. So 100 beats per minute. So we can agree with both methods that our patient is in normal sinus rhythm. And We can also just dive a little deeper here, and I'll show you that the P waves are upright and uniform on each one. The PR interval is within the normal limits of 0.12 to 0.2 seconds, and the QRS complexes are narrow or less than 0.12 seconds. And that tells us that the impulse is conducting properly through the AV node and enter the ventricles. Now you can get very into this and purchase a caliper, which can help guide you into measuring if you would like to do that for practice. This is the baseline rhythm we use to compare all others. So if you can understand what normal looks like, it becomes easier and easier to recognize that when something is wrong. So now that we've identified this is a normal sinus rhythm, let's use the same strip to practice calculating heart rate using the 6-second method and the large box method with other types of rhythms. I want you to take a moment to review this strip, and I want you, when you feel confident in identifying the rate of this, I want you to look to your classmates to your right and to your left and just verify with them to see if you all got the right answer. So I want you to confirm, what is the rate? Try using both the large box method and the 6-second method to verify. Do you think that this rhythm is regular or irregular? Do you see a P wave before every QRS? I want you to try and calculate the PR interval. So is it within the 0.12 to 0.20 seconds? Is the QR complex narrow or less than 0.12 seconds? So now that you've taken some time to verify, if you answered yes to all of those, then great. You've just correctly identified a normal sinus rhythm. Now let's do a quick breakout session. We're going to get into groups of 4, and we're going to utilize some visual representation. So we're going to do some rhythm comparison side by side, and then we're going to do a group discussion with some clinical presentations of real patients. Now that we've finished our side-by-side rhythm strip comparison, we're going to do our case-based learning, and we're going to look at real rhythm strips from real patients. Each case study includes a patient presentation and then an EKG strip to follow. So let's pull up the website here. Okay, so we have finished our side-by-side rhythms. We have done our case studies. Let's break for about 10 minutes so you guys can stretch your legs, get some water, and take a breather. And then we're going to come back to nursing actions and what we can do from here. So now that we're back from break, now let's talk a little bit about the clinical side of things. So we've recognized a rhythm, and I want to note that this is only part of the job. So now we've recognized it, what actions are we going to take? These 3 websites here we're going to dive into. These are the ACLS rhythms. So the big ones that we're going to talk about today are cardiac events such as cardiac arrest. We're going to look at bradycardia, which is our slower heart rates, less than 60, and then tachycardia, which is greater than 100. This part of the presentation, I would pull up these websites and we would walk through the algorithms of the ACLS protocol and stop to ask for questions during. As previously stated, the cardiac system is very intensive. I would, during my presentation, probably dive a little bit deeper into different arrhythmias, but I would try to break up this large content into 2 or 3 different lectures. As I previously stated earlier under my objectives, that this presentation integrates Knoll's adult learning theory by focusing on clinical relevance and encouraging self-directed learning. Kolb's experimental learning is evident in the rhythm interpretation and simulation activities, which would allow learners to apply, reflect, and adapt. By using a multimodal approach and building on learners' prior ER or clinical experience, this session supports a constructivist model of professional growth. To accommodate all learning styles, I've included this website that is provided through UAMS called Osmosis. It's a great tool that provides visual aids, study material presentations, quizzes, and transcripts for all learning styles. This will be a great tool to help solidify not only EKG information, but any other topics that students may want to review throughout their nursing careers. This presentation considers the needs of learners with disabilities or alternative learning preferences. Captions will be provided for videos, and all case scenarios will be available in both visual and written formats. Additionally, time and one-on-one support will be available as needed to ensure equitable access to learning. I would like to also emphasize that weekly office hours will be encouraged to clarify concepts and to ask questions for any students or groups. To help you lock in everything that we've covered today, here are the post-session assignments. These are going to be designed to strengthen your confidence and prepare you to apply EKG skills in real-world clinical settings. I have included 2 resources here. This is skillstat.com. You can review EKG waveforms here, and you can also print them out for handouts. And there is wonderful simulations within this. We'll pull this up shortly and go over our homework that will be due in a week. Lastly is the form to exit class today. This is a self-reflection exit ticket. So if you click on the link, you'll be able to fill out the form electronically. I'll give you guys about 10 minutes to fill this out, and it'll help you to reflect on what you learned today, what you think you need to improve on, and then put any concerns you have. I will review the forms, and then as we continue on in our cardiac journey, we will tailor our lectures depending on what you guys filled out in the forms. Okay, first of all, I want you guys to take 2 deep breaths. This was a lot of information today. Let's summarize what we've covered and how does it tie back to our learning outcomes. So let's go ahead and review key takeaways from today's session. First, we learned the components of the EKG waveform, including the P wave, the PR interval, the QRS complex, and T wave, and what each one represents electrically and clinically. We practiced 2 core methods for calculating heart rate, the 6-second method and the large box method. You saw how accurate lead placement is and how essential it is for reliable interpretation. And we linked specific leads to coronary anatomy to understand what each part of the EKG reflects. Now, we did interpret normal sinus rhythm, and we introduced some abnormal rhythms today, but tying them to clinical symptoms and nursing interventions based on ACLS guidelines was introduced, but we're going to continue on that journey. So don't stress about it now if it seems like a lot. This foundational knowledge isn't just academic, it's life-saving. As emergency nurses, your ability to quickly identify and respond to changes on the monitor can change outcomes, and it can change someone's life in a matter of seconds. So whether it's calling a STEMI alert, initiating CPR, or simply catching a subtle rhythm change, EKG literacy empowers you to lead at the bedside and inform your doctors and other staff. So I want to say thank you so much for your attention and keep practicing. The more strips you read, the more second nature it becomes. Now go out there, read some EKGs, and save some lives. Thank you so much for listening to this presentation today. I would like to do a quick recap on the core nursing competencies targeted in this lecture. We utilize clinical judgment, patient safety, communication, evidence-based practice, and informatics. At the end of our cardiac journey, learners will complete a post-session EKG interpretation involving 5 unknown rhythm strips. They'll have to identify rhythm, clinical significance, and list appropriate nursing interventions. Then a rubric-based scoring tool will be used to assess performance and accuracy, clinical decision-making, and communication clarity. These are additional resources that I will utilize and give to my students. Each one is a wonderful tool that can be found online to further enhance their knowledge of the cardiac conduction system, ACLS algorithms that include practice tests. There's also some wonderful EKG case studies, rhythm study guides, and then the last one is the EKG presentation PDF, which is a wonderful tool that they can carry around with them in their units. These are the resources used for my presentation.